Morning teachers and my dear friends. The topic of my discussion is alcohol. The most common symptoms that a patient present with in case of cardiac disease are chest pain, dyspnea, palpitations or edema. So let us consider them one by one. Algorithm is a beautiful way to reach to a diagnosis with minimal confusion and subjective bias. But it is in no way a substitute for clinical judgment and improvement. First of all, let us consider the diagnostic algorithm in a case of edema. So, the etiologies in edema can be related to 3 or 4 major systems. So, it can be either cardiac, it can be hepatic, it can be renal, or it can be related to systemic conditions such as malnutrition or other local conditions. So when we find a case of edema, the first thing to decide is whether it is bilateral and generalized or it is localized or unilateral. Now if it is localized or unilateral, then the diagnoses are totally different. Suppose a patient presents with localized edema of a leg, it can be due to inflammatory conditions like cellulitis of that leg and etc. If it is unilateral edema affecting the whole limb, then it can be due to obstruction of the venous or lymphatic supply. There are some certain lymphatic conditions in the pediatric population where there is congenital absence of the lymphatics that can lead to early onset lymphedema such as Milroy's disease, etc. Or it can, in the adult population, it can present due to fibrosis of the lymphatic system in diseases such as filariasis or due to removal of the lymph nodes in certain surgeries requiring lymph node dissection. The venous causes includes deep venous thrombosis or thromboembolism that occludes the arteries of the limb. Now, if the edema is bilateral, generalized, which can be associated with either ascites or pulmonary edema, then it can be due to either cardiac cause, renal cause, or hepatic cause. These are the 3 most major causes. Now, we assess the JVP. If the JVP is elevated, then it is most probably indicates increase in the fluid, the intravascular fluid level. So, as we know, in the basic pathogenesis of edema, the most important factors are the starting forces, which includes either the increased hydrostatic pressure or the lowered oncotic pressure. So, if the JVP is elevated, it indicates a increased hydrostatic pressure. So, it can be the hydrostatic pressure can be elevated in conditions of cardiac failure because the heart is not able to pump the blood forward. So, there is back pressure resulting in edema in the organs that are behind. It can be seen in the renal failure, chronic renal failure, because there is retention of sodium and water, which results in increased intravascular volume. Or it can be as a result of iatrogenic fluid overload, which occurs when there is overzealous fluid resuscitations. Now, suppose the JVP is not elevated. So, what can be the other possibility? It must be that the oncotic pressure is decreased. So, the oncotic pressure can be decreased, it means that there is less protein. So, if there is less proteins, it means either synthesis is less or more of it is excreted. So, we do a serum albumin. So, if the serum albumin is low, then we will see if there is proteinuria. If there is proteinuria, that it means that the proteins is being lost. So, if the proteinuria is greater than 3.5 gram per 24 hours, then it is a clear indication for nephrotic syndrome. And if there is no proteinuria, it means that there is less synthesis. So, it can occur in case of chronic liver disease, where there is decompensation like hepatic failure, or either the intake is less, as is seen in malnutrition. Suppose the serum albumin is normal, so the causes can be either it is lymphatic or venous obstruction in the proximal part. As I said, lymphatic and venous obstruction can lead to unilateral edema. It mostly leads to it, but for example, if the obstruction is more proximal, suppose there is an abdominal mass that is pressing on the IVC or the common iliac or internal iliac arteries, then it can lead to bilateral edema in the both legs. Or it can be either due to some not so common causes like the use of drugs such as non-steroidal anti-inflammatory drugs and calcium channel blockers. On the left side, we can find a list of examination and investigations that are particularly helpful in reaching to a diagnosis of edema.
So see, just one minute. See, one thing realistic, you can add whether this edema is it is generalized, then you can add two categories. One is proportionate anasarca and disproportionate anasarca. So in the proportionate anasarca, all the conditions like lactic, cardiac and the renal count. In the disproportionate, it is the usually hepatic cause or local cause. And or cardiac cause, on the cardiac cause, giving rise to disproportionate anasarca is constricted pericarditis. And among the hepatic cause, it is hepatic failure, hepatitis, chronic hepatitis cirrhosis. Usually rise to ascites out of proportion to that of edema. Whereas in other condition, it is proportionate. In edema, which is proportionate on the all part of the body, the same amount of the fluid is present in the diaphragm cavity also. So that is what is proportionate and disproportionate. So this restricts your diagnosis to, if it is disproportionate, starting here with the obstructive pericarditis or a local abdominal cause, hepatic cause.
Just to add to this, when I was a postgraduate student, there was one case in emergency who came with a child with massive ascites. And we gave a diagnosis of chronic liver disease, massive ascites. We could not palpate the liver. Ultrasound, we didn't get an urgent ultrasound done. So, but when my consultant came on round, next day, he just palpated the pulse and he said, this is a case of constrictive pericarditis. Just by feeling the pulse was so thready that he said this is a case of constrictive pericarditis which led to the massive ascites. And it was proved correct. So just to remember, always feeling for thready pulse and then see for heart sounds. As sir said, right, disproportionate anasarca, massive ascites out of proportion to edema resting body could be a case of constrictive. So that I never forget now. Some things in clinical practice that some senior tests that we never forget.
This is a flowchart from Harrison's that shows the approach to a case of edema. It is almost the same. It says if there is a case of edema, we have first decide whether it is localized or it is generalized. If it is localized, the causes can be venous or lymphatic obstruction or it can be local injury. If it is not localized, it is generalized, we find the serum albumin levels. If it is less than 2.5 gram per deciliter, the causes can be either due to reduced intake like severe malnutrition or due to reduced synthesis like cirrhosis of the liver or due to increased excretion like in nephrotic syndrome. If the albumin levels are normal, then we assess the JVP and the cardiac output. If the JVP is increased and the cardiac output is decreased, then it indicates heart failure. If it is not that, then we assess for the renal function test. If there is signs of azotemia, then the most probable diagnosis is renal failure. If none of these tests turn out to be positive, then we should consider other rarer diagnoses like drug-induced or due to hypothyroidism.
Cause of edema and hypothyroidism.
Accumulation of glucose
And hypothyroidism. Why non-hepatic edema?
Because there is no fluid, it is the disadvantage of the algorithm is that it includes limited number of diagnoses, so it is not a substitute for clinical judgment. So maybe some diseases, for example, lymphatic or venous obstruction can also present in bilateral edema. So it basically tells us about a classical presentation. So it is only advisable in emergency settings or low resource settings. This is the diagnostic algorithm in case of a chest pain. If there is chest pain, it can be either pleuritic type, which is aggravated by movement and respiration, or it can be related to, it can be like a tight band-like substernal pain, which is related to myocardial ischemia. If the pain is retrosternal and band-like squeezing and radiates to the left arm or the jaw and is precipitated by emotions and exertion, then the diagnosis can be either it can be unstable angina or myocardial infarction, or it can be stable angina. Stable angina relieves on rest or on taking nitroglycerin. Unstable angina is similar to stable angina, only that the episodes constantly increase in frequency and severity. And myocardial infarction, the hallmark of a myocardial infarction is that it is usually longer lasting and it is not relieved by rest or nitroglycerin, and there is autonomic symptoms like vomiting, sweating, etc. Just as I previously mentioned, an algorithm is not a substitute for clinical diagnosis because there is a condition called silent angina seen in diabetics with neuropathy, in which there can be a myocardial infarction without any pain. So it is always advisable to have an alert mind. The other cause of chest pain can be pleuritic. So if the chest pain is like central and it is relieved by sitting forward, then it is most probably due to pericarditis. And in pericarditis, on auscultation, a pericardial rub can be heard. Now, if the pleuritic pain is not in the central, but it is lateralized and present with a pleural rub, then we should see for symptoms of chest infection. Signs and symptoms of chest infection which can indicate pneumonia, which is extended to cause pleuritis. Now, if there is associated signs and symptoms of infection like breathlessness, but there are no signs of consolidation, but the heart rate is increased and there is cyanosis and the pain is of acute onset, then we can consider pulmonary embolus. There are other risk factors associated with pulmonary embolus like prolonged bed rest, immobilization, surgery, etc. Pneumothorax, it presents with lateralized chest pain, pleuritic chest pain with pleural rub, especially in young patients, acutely precipitated by exertion. The air entry is decreased and the patient is acutely breathless and tracheal deviation may be seen in huge pneumothorax. Musculoskeletal pain, chest pain is the hallmark is tenderness of palpation. Esophageal reflux disease, it is aggravated by lying flat after having meals and it is burning sensation. Aortic dissection is an emergency and the pain is characteristically very severe and radiates to the back with unstable vital signs. The useful investigations in this case are chest X-ray to see tracheal deviation or widening of the mediastinum, ECG for myocardial ischemia, cardiac enzymes for infarction. In selected cases, patients' arterial blood gases, CT scan, ventilation perfusion ratio, D-dimers and endoscopy can be performed. This is a table from Harrison that lists the most common diagnosis in a case of acute chest pain. It can be acute myocardial infarction, which is present with substernal squeezing pain lasting for more than 30 minutes, not relieved by rest, and associated with autonomic symptoms. It can be aortic dissection, which is very severe, radiates to the back. It can be acute pericarditis, which relieves on sitting forward and which is associated with a pericardial rub. It can be pulmonary embolism in a patient with the appropriate risk factors and associated with breathlessness or hemoptysis. It can be acute pneumothorax, which presents with breathlessness in a young male with a history of emphysema. It may be associated with a history of emphysema, or it can be rupture of esophagus if there is a history of prolonged retching. The diagnostic algorithm of SOC is very important because to decide what should be our strategy in a case of SOC. For example, if the case is of a hypovolemic SOC, the appropriate immediate management is to resuscitate with fluids. But the same can be detrimental if it is a case of cardiogenic shock. So it is very important to decide in a fraction of a time what kind of shock it really is. The diagnosis of SOC depends on the low blood pressure, cool, clammy peripheries, low urine output, and the heart and the respiratory rate. The blood pressure is a late indication of SOC and it is affected only in case of decompensation. Now, first of all, if the signs and symptoms of SOC are present, we check the JVP. If the JVP is high and the skin are cold and the lungs show repetitions, that is pulmonary edema, then that probable etiology is that the heart is not able to pump the blood forward. So it can be a case of cardiogenic shock. So it can be after an acute myocardial infarction due to some valvular lesions myocarditis or arrhythmia. The most, if it is a cardiogenic shock, then we proceed with inotropic agents. Pulmonary embolus leads to acute right heart failure, so it can present with similar symptoms of cardiogenic shock. If the JVP is low and we get a bounding pulse and a warm skin, then the most probable diagnosis is septic shock or anaphylaxis, which are included in the category distributive shock. What happens in distributive shock is that the peripheral blood vasculature is dilated. So instead of finding cold, clammy peripheries, we will find warm peripheries. So in that case, the JVP is not raised. Now, again, if the JVP is reduced and it is associated with cold and clammy skin or postural hypertension, then the most probable cause is hypovolemic shock. So to sum up, there can be a low JVP. If the JVP is low and the extremities are warm, then it is distributive. If the JVP is low and the extremities are cold, then it is hypovolemic. And if the JVP is elevated, it is cardiac. This is a diagnostic algorithm in case of arrhythmia, and arrhythmia commonly presents with either palpitation or syncope. So we first see the heart rate. If it is less than 60, which is bradycardia, or greater than 100. Now, after assessing the heart rate, we find out if the patient is stable or unstable. If the patient is unstable, we consider immediate cardioversion or pacing. If the patient is stable, we obtain a 12 with ECG. Now, if the rate comes out to be less than 60, it is a bradycardia, which can be sinus bradycardia, junctional bradycardia, or ilioventricular rhythm. Now, if the rate is 100, we find out if the PR interval is regular or if the PR interval is irregular. If the PR interval is regular, then we find out if there is a P wave before the QRS or there is no P wave before the QRS. If there is a P wave before the QRS, it indicates that the rhythm is originating from the atria. So it can be sinus tachycardia. If there is no P wave before QRS, then we analyze the QRS complex. If it is a narrow QRS complex, then the impulse originates from above the ventricle. That means it can be supraventricular tachycardia or atrial flutter with a fixed AV block, since the PR interval is regular. And if there is a white QRS complex, it means that the pathology is within the ventricle. So it can be either ventricular tachycardia or supraventricular tachycardia with an aberrant bundle. That means the impulse is originating above the ventricles, but it is not conducted by an AV node. It is conducted by an aberrant pathway. Now, if the PR interval is irregular, then it can be either due to atrial fibrillation or if there is an atrial flutter with a variable AV block. The classification of arrhythmias is essential because for every arrhythmia there are different agents to be used. For example, for ventricular arrhythmia we can go for cardioversion or drugs such as lidocaine. For supraventricular tachycardia we can go for beta blockers, adenosine or calcium channel blockers, etc. So, and for example, there is an aberrant bundle, then digoxin, which is used in atrial fibrillation, atrial flutter, etc., should be avoided because it can rather make the condition worse. This is the algorithm in case of a dyspnea patient. This is from Harrison. So we proceed with the history, physical examination, chest radiograph, and other science. So the causes can be categorized as it can be either due to cardiac cause, it can be due to respiratory cause. If the cause is cardiac, then dyspnea can be due to cardiac failure, due to valvular disease such as mitral stenosis, it can be due to congestive heart failure, and so we look for the appropriate sense. If we suspect a pulmonary mechanism is involved, then it can be due to interstitial lung disease which interferes with the diffusion of gases, or it can be due to pulmonary embolism and other conditions. Now the other conditions are if for example the respiratory mechanism is not impaired, the cardiac mechanism is not impaired. In fact, the cardiac output may be high. In such cases, we should assess the hematocrit because it may be a case of anemia, or we should also do the thyroid function. We can do the thyroid function test to rule out higher output cardiac failure. This is the algorithm for murmur. Murmurs of grade 1 and 2 and mid-systolic are generally physiological and can be heard in patients with fever or in pregnancy or in young patients. But if the grade is, if it is more than grade 3 or it is a holosystolic or late systolic murmur or if it is a diastolic or continuous murmur, then we should go for cardiac testing.